So it's a policy, it's a protocol that we all are going to be trained to and you'll be competent to, that you can do this independently. You do not need a physician's order for this or a provider order. This is something you do independently and you involve everybody independently, right? Everybody usually starts at 2. So we'll talk about the kind of the stepwise protocol. But basically we kind of move people up and up and up, right? All the way to level 5 where they're actually walking in the ICU on a ventilator, right? There's a vented patient that's walking, right? There are contraindications, so you're going to learn what those are. Just like you have a safety screen and fail screen for SAT, SPT, there's one also for mobility, okay? If you don't mobilize them, they start developing more VAPs, more ventilator-assisted events, more delirium, more pressure ulcers, ICU-acquired weakness or bed rest-itis, right? And they have, they're back and forth in the hospitals. They don't recover as well, right? But if we do it, we have better outcomes. We have better length of stays, better or improved mortality. And again, we talked about level 1. We talked about ARDS. That's where you're doing like CLRT and you're doing proning. That's your sickest of sick patients. But usually everybody starts at level 2, unless they're level 1, right? If they're really hemodynamically unstable, yeah, we'll start, we'll just go easy with level 1, okay? So you can mobilize patients with the most advanced devices, right? So this patient has, I think this guy has an ECMO in place, right? Yeah. So he has an ECMO, he's walking around, right? So he has an ECMO device, he has the ventilator, or he's extubated, he's like on vapotherm, but you can still mobilize these patients, right? The only contraindication we have right now is someone with a balloon pump slash Impella in the femoral, but you can do that in other ICUs. If they have that, they can walk as long as they, of course, meet the criteria, right? When you get an Impella initially, usually you're really, really sick, but day 2, day 3, day 4, we can consider, let's try to get them up in bed. Let's sit them up in bed. Let's try to, work on trunk strength, and we can keep progressing them when they are, this sick. So yeah, so the consequences are delirium, as we mentioned. Delirium can independently be improved by mobility, and if you don't mobilize someone, they are going to get delirium. So it just makes sense to mobilize the patient, right? They get poor cognition, they have poor functional outcomes. As we mentioned with delirium, they get a lot of poor outcomes outside of the hospital, outside of the ICU, once they've already developed it, right? And they get this ICU-acquired weakness or this critical illness polymyoneuropathy. So that is something that develops every single day. A COPD patient is at higher risk. An elderly patient is even higher risk, right? You lose about 3 to 11% of your muscle mass every day as a 35-year-old or a 45-year-old. But the older you are, you're going to get it even more, right? Again, within 48 hours, this can happen. And it's the highest at 2 to 3 weeks, where you're losing a lot of muscle mass. So this critical illness itself, right, you have the high FiO2 causing damage. You have the bed rest causing all these problems here, right? You get bone breakdown. They're not going to be, they have risk for fractures on the outside if they were to fall like outside of ICU, or they have decreased muscle strength, so they can't get out the ventilator, they can't wean well, they can't mobilize well, they have a more inflammation, they lead to more hypoxia because they have atelectasis, they can't move their diaphragm effectively, right? They get delirium, and they get more sedation, and you get more sedation, then we have more delirium, and then we have more psych problems, we have more impairment, and we have more burden on the families to begin with, but also independently increased mortality risk and more ICU days and a lot more problems, right? And it in of itself, if you don't mobilize, leads to more permanent immobility, okay? And it affects every organ system. So we have to do our part to kind of figure out what can we do to fix it, because the harms of immobilization are many, right? Cardiovascular-wise, we want to train the baroreceptors, otherwise they go away in 3 to 5 days. And now when they try to get up for the first time, it's going to be very, very difficult to get them off and get them mobilized compared to someone who you were actually rotating with CLRT therapy. Right? They get atelectasis and pneumonia, as we mentioned. They get ICU-acquired weakness. They get thromboembolisms as being on bed rest for a prolonged period of time. Right? The pressure ulcers don't help things. So these are all things that develop over time in the hospital setting, and then just being a survivor of ICU. Right? This post-ICU syndrome is something that develops where, yeah, you get caregiver burnout, but also the patient is not where they were. They get PTSD, impaired cognition. They're no longer at their level where they could be employed anymore. They get chronic pain, neuropathic pain. Now they're with pain and debilitated, and that's not a good situation for them to live in, nor for their caregivers. So this is our mobility protocol. Again, everybody starts at level 2. And this stuff you should be doing anyways. Head of bed 30 degrees, passive range of motion, turning Q 2 hours, right? Passive range of motion, that can be taught to the families. They can do that, right? You can develop trust with them. It's like you just move these right here, move the arms right here. Has an A line in it. It's like, don't touch that one, but do the other one, right? So they can move the patient around. That's perfectly fine as long as you have that kind of contract with them. We try to get PT to do it, but it's a whole thing. They can't bill for it. It's a process. But once they can start doing things, that's where you're going to start getting PT in on them daily, right? At the first, level 2, it's PRN, right? PRN, we might get PT involved. But once they start being able to tolerate a chair position, that's where you put them chair mode in the bed, or you get them in a combolizer twice a day. If they're tolerating that, you definitely need to have a PT eval. Now they can work on trunk strength, right? They can work on dangling, and where they're sitting up at the side of the bed, and they don't just fall back because they're super weak, right? So that works on the trunk strength, works on orthostasis, it works on progressing them through this mobility pathway, right? So level 2, everybody starts there, and then we keep going more and more. So what does level 2 do? Chair position, right? That's kind of what we're working on. We get in the chair twice a day. And then we get to level 3, it's still chair twice a day, but we go actually one more time, 3 times a day with breakfast, lunch, and dinner, for instance. And then the PTs working them with mobility to get them, with trunk strength, and they're actively doing range of motion. They're with the process, right? Can they do this if they're RAS of -1, -2? No. That's why our early mobility protocol says 0 to -1, so we can get them through this process, right? And then level 4, they're actually marching in place. So they have trunk strength. They're able to sit at the side of the bed as let's go ahead and stand, right? And start bearing weight. And let's start marching in place even. And they're doing that twice a day. So PTs are working them twice a day at that point. And then now it's occupational therapy, right? PRN. So let's bring occupational therapy who works on Sudoku puzzles and starting ovens and doing brush. You're not going to do that in ICU. You're going to be brushing teeth. You're going to be doing self-care and such, right? Doing the writing messages and such. So OT can start working them at that point, and then level 5 is where you're actually ambulating the patient, right? Where you're actually getting them up out of bed. They were marching in place first, and now you're actually moving them down the hall, right? First about 20 feet to the door and back, and then it's down the hall with the ventilator and such. So what equipment do you need? So the equipment you need for prior to ambulation, you probably need to grab the combolizer. That's our upgraded cardiac chair, and the battery failed like a month ago, and we ran into a situation, but we always have the cardiac chair to work with. But the combolizer is a great tool because not only does it chair, but you can actually sit them upright. They can actually put pressure on their legs to work on leg strength as well. And if you don't trust the combolizer, your bed, the footboard there supports up to like 400 pounds. So you can actually have them sit on the side of the bed, or not sit on the side, but Trendelenburg the bed, so they're able to push. Actually put weight, and they can work on orthostasis with their with them upright. The head of bed is going to help with that too. Okay, so your Hill-Rom bed will do it. That's the ones we have. The Progressa is our go-to one if you really want to start mobilizing a patient. It's great because it actually has like an egress mode where it goes chair mode, but then it'll actually lower it and get them down. You can take the footboard off, they can walk away, right? So it's It's beneficial for that reason as well. Okay. If you are going to ambulate them down the hallway, or your level 5, you need to have your Sarah study, which nobody uses. Like, no, I'm not going to use that. Right? But it is actually a great device. It actually is motorized. They can actually get to a standing position. And there's even a sling attachment we can get from ARU. And now if they get weak, you catch them in the sling and just put them back in bed. All right. Otherwise, once they get a little stronger, you'll need a wheelchair to follow them. If they get tired, they can just sit back down. We could get a walker or the Sarah Plus. All right, we need an IV pole. You need the good IV pole. So I have a picture coming up with the good IV pole. It's the one that looks like a T, right? That's the good IV pole. It's nice and strong. It can support like 2 IV pumps on it. It's the better one, all right? And there's like an attachment with the O2 tank that we can grab as well. All right, the transport ventilator as well. The ventilator itself has a battery of like 60 minutes, but it won't tell you. So you never know. So you just have 60 minutes, and someone has to have an internal clock that it's going to be, but that it's not going to go dead on you. But it's better to get the transport vent. Okay. And then personnel, you do need an RN, RT needs to be there, the tech can be there, the CNA, and the physical therapist is there to help assist as well. All right. So when are there contraindications? So you can do all of this stuff unless you meet these safety screen checks, right? So you might just delay it for 12 hours or 24 hours if all of a sudden the vasopressor requirements go up, or they have new ST changes, ST elevation, ST depression, or T wave inversion. right? ST elevation or ST depression, T-wave aversion, that'd be reason to hold off for another day. Or they have like AFib RVR, or they go into like episodes of VTAC, a lot of PVCs and ectopy. Wouldn't be a great idea to start, mobilize them today. We wait till tomorrow, right? And absolute contraindications. When would you you say, oh, Aaron told me to mobilize them. It's like, but did you do these criteria here? If they have uncontrolled ICPs, they're not going to be mobilizing. If you were to mobilize an ICP, it's an advanced maneuver. You would clamp it to make sure the brain doesn't drain on the floor. So there's that's you want to make sure that we are doing it safely, all right? And receiving therapy is restricted mobility. They have they're pacer dependent. So probably not a good idea. It's like, I know that I'm going to make that pacer work hard. I'm going to change that battery twice the shift now, right? So it's not a good idea to do if they're on transvenous pacer or transcutaneous pacer. Balloon pump / Impella, right? Those are for cardiogenic shock. Probably not the greatest piece. Usually we do it when we're coming down on vasopressors. That's when it's a good idea to kind of consider mobilization. They have an open chest or abdomen. We don't usually have many open chests, but open abdomens, they might get back from OR with a big wound vac in place. They're not ready to mobilize just yet. And then unstable fractures, we don't see those as common because we're not doing as many traumas, but that's someone who has a femur that's still fractured, right? They just came in and we found out on CT they got a fractured femur. Like, well, we're not going to mobilize them the next day, right? We're going to wait till that is fixed. And then neuromuscular blockade. It's very hard to mobilize someone if they're paralyzed. All right, but every day you need to decide, do they still need this paralytic? Because the paralytic itself, besides steroids, besides electrolyte changes, in of itself causes you to have muscle breakdown and the critical illness, polyneuropathy, myoneuropathy, active bleeding. Right, we don't want to have a big cleanup mess, but also they're probably not going to pass out on you. We want to make sure we have a stable hemoglobin before we start mobilizing. And then prognosis, right? You have grandma on 4 pressors and she's 97 years old. It's like, we're getting up, grandma, right? So that's not the time, right? If they have their comfort care, it's like, I know this is going to improve things, right? No, it's not time to consider doing mobilization if they're comfort care. Or if they're DNR, yes, you can, but comfort care, no, all right? And they're going to transfer out of the facility. It's like, you're going to walk to your new hospital. No, we're not going to be doing that, right? We're going to let them, fix them at the other hospital and they can start the mobilization process. All right, so as you're mobilizing them, this is not someone that has failed, has met criteria to not do it, or it's not someone who's passed the safety screen. They don't have any contraindications. They don't have any relative contraindications. It's someone who you're actively mobilizing. So who is, when you say, oh, that's enough, we're stopping it. Who is that? It's someone who has, change in vitals at level 1. All right, you're doing the CLRT, you're doing the proning, and all of a sudden their pressure starts dumping and their stats don't recover. It's like, oh, they're not tolerating that, let's flip them back over, right? So that'd be someone, that's like a level 1 situation. Level 2 to 5 though, that's where you have like a 20% change in vitals, right? The blood pressure was 140, and what's 20% of 140? 28 points, right? So 10% is 14 plus 2 10% is 28. So a 28-point drop or 28-point rise in our blood pressure, so a 20% change, then that's a consideration to stop the activity. Or heart rate. Heart rate's 100. Let's make it easy. And what's a 20% change in heart rate? Yeah, so the 20 points elevation, right? So go to more than 120s, that's a problem. If they stop breathing on you, that's a problem too. Respirate less than 5, right? Or respirate rates greater than 40 that you can't calm them, work them through, right? They start getting agitated. They start being violent and punching you. I'm not getting up, right? So that's someone you're probably not going to. You're going to fail them. You're going to say, okay, we're going to try again, this afternoon or something. Okay. If they lose a line, a tube comes out, it's probably time to put them back in bed. And they did a lot of research. So the amount of lines and tubes that came out was a lot less than expected. Like even the most advanced patients that had a lot of lines, they didn't lose lines, right? You just got to do preparation. Like even when we prone patients during COVID, I could count maybe 1 patient that got extubated, and it's because they did it wrong, right? Someone didn't have someone wasn't watching the airway. So that's how many patients actually get tubes pulling out is very, very little. Right? Unless that tube is like this Perfil IV that's has only a little tiny piece of tape and it's halfway out. Yeah, that's going to come out. All right, so that's the idea behind mobilizing patients.
He spent 299 days at Providence Portland Medical Center in Oregon. 108 of those days were spent on ECMO, which is a heart and lung bypass machine. I didn't know you could be on ECMO and be awake.
Yeah.
And walk.
Yeah.
That's unbelievable. Would they walk him like this every day?
It'd be maybe 3 days a week.
Alex's oldest son, AJ, showed us family videos of Alex walking in the hospital as blood was being pumped out of his body and then back into it, doing the work of his heart and lungs as he walked.
The healthcare workers and the nurses and the doctors all in the ICU they're godsend. They literally saved my dad's life.
Alex had the heart of a lion.
Levi Cole was one of the ICU nurses who cared for Alex.
He fought like an animal, and he made it out of here
against every possible odd. How does it make you feel to hear that?
Happy.
Right, so it's really good to mobilize patients, right? It makes everybody happy. So we have, we got grandma happy there, right? She's on vapotherm, right? We got our tracheostomy here, and look how happy our families are when they see their loved ones getting up out of bed. And like when you put them in a combolizer, you put them in a chair, it's a bigger, much bigger difference compared to just like in the bed. Like they're ready for an SPT. Now they're really, really ready when you have like in the combolizer or even in the chair. A chair without wheels, please. You get any chair and it works, right? But as long as it's a chair without wheels, and that's ideal. All right, family. All right, so that's our next last section, is making sure that our families are empowered to speak up, and they are, they can even come forward. They can make sure that they are going to the front of the line to make sure that they are, in medication complications, assessing whether this is a change in status, right? They come in, it's like, oh, my husband wasn't like this yesterday. What's going on? Well, that's your first clue that they might, be CAM positive, right? That's one of our first features. So yeah, it's patient-centered. So you want to make sure that they are, the patient is important. They are the most important, because family can get out of control. That can happen. So it's, it's a agreement that we're all on the same page and we are going to improve, right? We don't need the whole, 7 generations of family in the room, right? ICU is 3 visitors at a time, right? 1 overnight and 1 during shift change. So we don't, after that, then yeah, 3 patients, 3 visitors is fine. But we're not going to, again, not having, crock pots stewing outside. We're not going to have a tailgate party outside, right? We had a young kid who was in his 20s, and he had E2H cardiomyopathy because he drank so much alcohol. He was over in 52, and you could look through the window and see the family down there all drinking beers, and so it's like, so are they supportive? We got to be on the same page. Okay, so yeah, so we want to make sure that we are, make sure we respect their values and cultures and such, and respecting their, their DNR wishes, their pulsed wishes. So that's an important piece, but also, you want to keep them in the loop. You want to make sure we're not have angry families. That doesn't help anybody recover, because when they're stressed, they're in the room, that stress then gets kind of translated. So you want to make sure they're actively involved, they know what's going on. We encourage us to, give the family an update by 2 o'clock, right? 2 p.m. on day shift and night shift. You give a report, say, hey, have you updated the family yet? They either say there's no family, or yes, I updated them today, or they haven't. There's a really busy day, then we can update them like at 9 o'clock after we get our meds passed and such. All right, just give a quick update, say, hey, they're doing good. We're coming down the vent settings. X-ray looks a little better today per the intensivist. And I just want to let you, if you have any questions, right? And that's going to curtail a lot of angry family members, right? And of course, we make sure there's one person, and they let them know that they need to explain that to all 7 generations, right? We can't be making 75 phone calls during the day or at night. Don't be that nurse that's super nice and updates every single family member, because the next nurse is going to follow the rules, and then they're going to be the bad guy. Okay. So social isolation. So we used to keep ICUs closed, and families could only visit for 1 hour out of the day. And we found that patients got socially isolated and they had bad outcomes. So you want to have open visitation, and within reason, as I mentioned, right? You want to invite them to rounds. They are a part of rounds. They should be at the door discussing, so they kind of understand. You want to prep them and let them know that it's not this is not a time to ask 75 questions. Let them know, hey, if you have questions, and like immediate questions, we can answer them, but detailed questions, the intensivist could come back and talk to you afterwards, right? Let them know we're going to be discussing. You let them know who's going to be there. We have all the people there, right? We got some family right there. We have the pharmacist over here. We have the intensivist. Maybe we got someone shadowing there. Or we got the nurse, we got the charge nurse, we got the RRT, or I think you could call an RRT to the 2nd floor. So it's the whole group of people are involved. Physical therapy is there, occupational therapy, nutrition services is there. They're all there to help coordinate and make sure they chime in, right? Because someone's going to forget, hey, they haven't ate in a while. Do I see any tube feeding here? Nope, I got an A line there, I got pumps there. There's no, someone's doing their subglottal suctioning, and we got the patient on ECMO over here. We got the patient on the ventilator still. We're not 30 degrees. So then the PT's like, hey, why don't we raise the bed up a little bit? I'll work with them a little bit. And then you got, dietary and nutrition services say, hey, I don't see any tube feeding. Can we start tube feeding, right? Or they say, hey, I haven't seen them have a bowel movement in a little bit. Or they can say, hey, I'm going to increase the protein calorie density today. So you want to have all these guys contribute their expertise. Okay, so benefits, again, they decrease anxiety, they decrease ICU length of stay, right? You might have some little older nurses that don't believe in that, oh, they interfere, but they are actually beneficial when we work with them and have a contract. If they are interfering, we do want to have a contract with them and let them know you're going to be the point person and just let you know how things work. Okay, so post-ICU syndrome we've been touching on as far as what happens after they leave the ICU. They can be a huge burden on the family because they are, they developed a delirium within the ICU, and they had now they don't have good functional recovery afterwards as far as cognition is concerned. And then on the flip side, mobility-wise, they had ICU-acquired weakness, and now they don't recover outside the ICU, and now they are dependent on their caregiver. And that can cause decreased quality of life for them and also be a lot of stressors for the family, right? So ICU-acquired weakness happens in about 33% of events, 50% of events, vented patients after 7 days. It usually takes about a year of fully recovery, and some people don't, right? Up to like 30% of patients don't recover, and they are permanently with disability or unable to move at all. And then cognitive brain function, again, some never recover, right? They're permanently disabled. They can no longer do problem-solving skills. They can't recall things. They leave their car running in the garage for, because they forgot. They should be driving the car in the first place. But at the same time, they are at risk, right? And then mental health. They got insomnia, PTSD, depression, anxiety. Suicide's kind of been ruled as not directly related, but we know that PTSD and depression can lead to it. Okay, so there's a lot of problems that can lead afterwards. Just like simple thing as difficulty swallowing now. Now they have to have like tube feeding for a long period of time until they can regain their strength of upper airway muscles, right, upper swallowing muscles and such, right? So quality of life is usually what we're looking at when we try to get them out of the ICU, and we can do that. We can improve that by improving mobility and assessing for delirium, making sure the pain's under control, make sure that the plastic is out of the patient, and the ventilator is out of the patient as well. Okay, so prophylaxis, right? We're making sure that we're doing these things, all the ABCDEF bundle, to get them healed and out of the ICU, right? And again, you don't want to keep patients in the ICU because they actually, just being in the ICU itself, even with very little problems, that can cause you to develop delirium in of itself with all the beeping and monitored and such. And that you have a lot less, not care, but you have more interventions that are done on the floor, right? When a patient moves out of the ICU to the floor, the telenurse or the med-surg nurse are getting up or walking around the unit today, right? We're gonna, get up for your meal. We're gonna, they're gonna make sure they're eating. They're gonna make sure they're doing all these things to prepare them for discharge. Whereas in ICU, we're not really discharge focused. We're about fixing the problem right in front of us, right? So establish goals, make sure that we let them know right on the whiteboard, hey, we're getting up and we're doing, we're getting out of the chair two times a day, right? That's our goal. We're make sure we're doing range of motion. A family can check the box on the board, right? Maintaining our optimal ICU parameters, make sure blood pressure is good, heart rate's under control. We're doing all these things to avoid complications of immobility, of which there are many, besides just straight up delirium, right? Which we know then can independently cause more problems, okay? You want to communicate with the family and the patient, make sure they know what's going on, and make sure they help reorient the patient, and make sure they can read aloud at the bedside, they can play music, they can do a lot of things to help progress the patient within the ICU. Okay, so again, the ABCDEF bundle, that's our goal of liberating from the ventilator and also liberating from the ICU in of itself, right? It independently gets patients out the ventilator, independently gets patients out of the ICU. The length of stay in the ICU is decreased. It independently decreases mortality and decreases this post-ICU syndrome when we actually are integrating all these pieces, all right? So that's your ABCDEF bundle. Okay, all right, so exhale your tidal volume.